Welcome, Tara.
All right, thank you, Elizabeth. So I'm happy to chat with you guys today. I'll kick off and talk just kind of about diagnosis and management, and then Justin will cover our pharmacologic treatment options for hypertension. We hope that both Justin and I can cover some things that are of most interest to you, but if you do have questions that we don't cover, you can submit those in the Q&A box and we'll take those at the end of the presentation. So without further ado, I will get started. So again, these are our disclosures. Objectively, again, our goal is to help give you a solid baseline knowledge of the diagnosis and management of hypertension, as well as the guideline recommended pharmacologic treatment options for this patient population. So one of the reasons that we selected hypertension as a topic of this series is because this is the most common chronic condition that is dealt with amongst primary care providers. So all of us, regardless of our clinical role and our area of expertise, are going to encounter patients that have hypertension. So if we break down looking kind of at prevalence, this is based on data it's a few years old, 2017, 2018. Almost half of all adults will have and carry the diagnosis of hypertension. This disproportionately does affect men more than women. And as we age, the incidence of this is going to increase. One of the more simple ways I try to explain this to patients is that as we get older, our vascular resistance increases. So it's going to take more force to get the blood through the blood vessels. So as we get older, we naturally will see that hypertension diagnosis become more prevalent. So once you get over the age of 60, about 3/4 of patients will have the diagnosis of hypertension. We also know now, looking really carefully at all chronic conditions and how much this affects people disproportionately, and what the racial and socioeconomic disparities are. So we know our non-Hispanic Black patients disproportionately are affected by hypertension, about 57%. We also know from a socioeconomic standpoint, hypertension is lowest amongst college graduates when you compare that to those with just a high school education or less, or those with some college. We find that this trend of socioeconomic disparity is roughly equivalent when you're looking at men versus women, but it is definitely a trend that is seen in the data. And they feel like this is driven by a couple of phenomena. Again, the older we get, the more likely we are to have hypertension. And we also have the epidemic of obesity, certainly in this country as well as throughout the world. So these two things primarily are driving the increased prevalence of hypertension in our communities. This is a nice graph, I think, that just kind of breaks down again those, and a couple of things that I think were really interesting I'll point out. Here on your left is all men and women combined. So this is everyone the age of 18 or older. Here in this kind of lighter blue, this is your 18 to 39 range. This is your 40 to 59, and then over the age of 60. So again, we anticipate that number to increase as age increases. If you look here at men versus women, one thing I want to point out is the significant difference between the 18 to 39 as well as the 40 to 59. You know, once you get to the age of 60 and over, the percentage of prevalence is not too far off, but there's a significant difference between men versus women in that age range between the age of 18 to the age of 59. Almost a 10% difference here in that 40 to 59 category. So just kind of something to note there. Again, this disproportionately is going to affect our male patients more than female. The diagnosis of hypertension at its infancy depends upon the appropriate assessment of blood pressure. And so I think it's worth taking a moment to really talk about the best way to measure blood pressure in a patient in an office setting. And that's not to rush them back from the waiting room, sit them down in the room and go ahead and check their blood pressure, because it's likely going to be high. One of the ways that we have asked our staff to do it here in our offices, once you kind of get the patient down the hall and into the room, have them kind of get settled, introductions, niceties, kind of asking them how their day is going through their medication list while they can kind of sit there and get calm. We do EKGs in our office, but if we were not, then we would go ahead and get the patient ready to have their blood pressure checked. Have them sitting in a chair with their feet supported, so not, hanging off the exam table bed. having them, again, in a very relaxed position with their arm being supported either by the staff member or on a table or a desk of some kind, making sure that we select the correct blood pressure cuff size. So having multiple options of sizes in the room if possible. And if you note that the blood pressure is elevated, give it a few minutes and recheck it again. Oftentimes I, as the provider, will go and do that once I'm seeing the patient. And again, I'll save that for the end. So if I notice that their blood pressure reading is elevated, once I go in and talk to the patient and kind of, talk about what's going on with their visit today, then I'll begin my exam and I will start it with listening to their lungs. So you're kind of forcing them to do some guided breathing, have them breathing deeply for a few seconds. Maybe even give them a little bit of good news before you do that. If their EKG looks fine or if their lab work looks fine, you can say things like, hey, your numbers look really good today. We'll chat more about it in a second, but let me take a listen and examine you. Then I'll recheck that blood pressure again in a few minutes, and most of the time it's come down. So really getting an appropriate assessment of their blood pressure really is the foundation to everything that we're going to build on further today. So this is the most up-to-date classification of hypertension based on the most recent updates. So you have your normal blood pressure range, which is anything less than 120 and less than 80 diastolic. Elevated blood pressure is when they are between that 120 to 129 range, but their diastolic is still less than 80. Then you have stage 1 hypertension, which is where their systolic is between 130 and 139. Diastolic is between 80 and 89. Stage 2 hypertension is 140 or higher systolic and 90 or higher diastolic. Once their systolic gets above 180 and or their diastolic is greater than 120, then that patient is in a hypertensive crisis. So again, this is the most updated classification. This does a nice job of showing you a bit of the difference between the previous classification system, which included that pre-hypertension stage that is now no longer part of the classification. So you can see here the normal range stayed the same, but that pre-hypertension range that we previously had has now been broken down into the elevated blood pressure versus that stage 1 hypertension. And then they combined the stage 1 and stage 2 of the previous classification into just stage 2. And so then you can see here a breakdown of the management. So obviously, patients with a normal blood pressure, you want to keep it that way. Continue to promote optimal lifestyle habits. Once they are then diagnosed with either elevated BP or stage 1 or 2 hypertension, then you, again, non-pharmacologic therapy, optimal lifestyle habits is a treatment for every single stage of hypertension. It's not that once we get them on medications, we can kind of throw those things out the window. Lifestyle modification is a treatment recommendation at every stage of hypertension. So engaging those patients in that, and then also evaluating them for the presence of atherosclerotic cardiovascular disease or what their 10-year cardiovascular disease risk score is. I will talk more about this here in just a second, but you kind of can go through this decision tree here to determine whether or not they need medical therapy or if it's not indicated. And again, for all patients, making sure they are scheduled for appropriate routine follow-up and making sure that they are aware of what those lifestyle habits should be. So the 10-year risk score, it's a national guideline that was developed by the American College of Cardiology. It is a 10-year risk of having a cardiovascular problem like a heart attack or MI or a stroke. And it takes into consideration the following things that you see here: how old the patient is. The older they are, the more at risk they are. The patient's sex, what is their race, what are their cholesterol levels, how well is their blood pressure controlled, are they compliant or adherent to their medication regimen, are they diabetic, and are they smoking? And so you can see here that breaks down into the risk score and the level of risk with each of those ranges and what the recommendations would be based upon that level of risk. So if you have someone that has a intermediate risk, 10-year risk score, they need lifestyle modification, they may need statin therapy. All of those, statin therapy and things like that will be covered in our later CME series this summer when we focus specifically on lipid management. But this is just to kind of explain to you the 4 different categories of the 10-year risk score. Now, within EPIC, we do have a smart phrase that will import this into your notes. So this will help show kind of your maybe thought process behind certain treatment recommendations. So this is in your EPIC smart phrases, it's .risk, and this is what it would look like when it pulls that information directly into your note. Now, one caveat here is that the components here must be current in EPIC in order to pull that into your office note. So for example, if the patient doesn't have a recent lipid panel or any lipid panel in, they're not going to be able to pull over those cholesterol readings. So they're not going to be able to give you the actual risk score. But so long as these components are entered into their EMR, then you should be able to use this. There is also an app if you are practicing somewhere where you don't have readily access to EPIC, or you want something kind of on the go. The American College of Cardiology does have this app where you can enter these data points in, and then they will give you that score accordingly. But again, this is something that you can put in directly into your office note to demonstrate what that is for the patient. So we'll do a little bit of a case study kind of throughout this and build on this as we go along, but Mrs. Smith is going to be our patient that we study for today. So she is a patient that you've been seeing for the last 2 years. She's a 63-year-old African-American woman. She has a history of GERD as well as hyperlipidemia that has been appropriately treated with a statin. On her last few visits, her blood pressure readings have been in the relatively normal range, in the 110s to 120s, with that diastolic mostly in the high 70s, low 80s. Her 10-year risk score is 6.1. So if we went back to that previous slide, that's going to put her in that borderline category. So if her blood pressure if you see here what her readings have been, what would you diagnose her with? So technically you looks like there's a poll here that's popped up, so I'll give you guys a moment to answer that. And so she would be diagnosed with, looks like we're kind of split here, normal BP, pre-hypertension, elevated BP, and stage 1. So in this instance, she would be diagnosed with elevated BP. Pre-hypertension was part of the previous classification system, so not wrong in that, but with the updated classification system, she would fall into that elevated BP range. She wouldn't be considered stage 1 quite yet, as her systolic was not more than 130. But we would say she definitely has some elevated BP. And so really focusing on those lifestyle modifications and talking her through some strategies would be important. So this gives you an idea of the impact on your systolic pressure that these lifestyle modifications can have. So really talking about weight loss, and that for every 1 kilogram of weight that's lost, you expect about a 1 millimeter of mercury reduction in their blood pressure readings. And so talking to them about strategies for weight loss and also their diet. So the DASH diet is the most commonly recommended diet for people with hypertension. DASH stands for Dietary Approach to Stopping Hypertension. This is essentially a healthy heart diet, a diet very rich in fruits and vegetables, whole grains, low-fat dairy products. The DASH diet is something that you can print out for your patients on your after-visit summary when you're seeing a patient in the clinic. You can, in that smart text, just type in DASH diet, and then that should be able to pull that up, and you can import that into their after-visit summary so that they're able to leave with something tangible for them to reference back to. Really talking to them about sodium intake. Most patients have been ingrained now to avoid putting salt on their food. Some still do, but it's oftentimes the amount of sodium that's already in the foods that we eat that patients often aren't aware of. And sometimes it's as simple as just having them take a look at the food labels for a couple of days and calculating that number up to know that they're probably really overshooting that 1,500 to 2,000 recommendation mark. Physical activity is another piece to this, as well as moderating their alcohol intake. Really talking through the physical activity piece here is that it can often be daunting if we're asking a patient to lose weight and be more active, and they feel like they need to do all of it at the same time, and it can be very overwhelming, and then they just say, well, forget it, I'm not going to do this. So I usually recommend my people start with one or the other. If you want to start with diet, or if you want to start with exercise, feel like you're comfortable with that, and then kind of start adding those things in. Activity can be a really hard thing to sell because they think they need to be working out for an hour every day. I have them just try walking for 5 to 10 minutes a couple times a week, and then gradually adding on to there. If they can start small and kind of make these small manageable goals and achieve them, it will help encourage them to continue and increase that to where they are, you know, having some aerobic activity for at least an hour, a couple of times a week. So things that we can talk to them about as far as alcohol intake, the recommendation from American Heart for Men is no more than 2 drinks per day. A drink is a can of beer, a 5-ounce glass of wine, or 1 ounce of liquor. And then for women, that is no more than 1 drink per day. If my patients feel like I can go without alcohol, great, that's awesome. But if they really enjoy that nightly glass of wine, quality of life is important. So just making sure that they keep that in moderation. Majority of patients are going to have primary hypertension. This is 95% of cases. And this is primarily those risk factor mediated things like alcohol, smoking, family history, obesity, ineffective stress management. I think that would be like 100% of us. I don't know if any of us particularly manage stress in the most efficient way. Secondary hypertension really is much more rare. This is only going to be in about 5% of your cases. This is hypertension that's the result of some other chronic or underlying condition like adrenal disease, hyperparathyroidism, or thyroid disease in general, primarily hyperthyroidism, sleep apnea that's untreated or inefficiently treated, coarctation of the aorta, pheochromocytoma. So there are a lot of these things, but these are more of your zebras rather than your horses. So medication induced can occur as well. So this is I felt like was a very helpful chart to kind of talk through some of these secondary causes of hypertension and what diagnostic studies you would do. So if you find the patient has a lot of snoring or daytime somnolence, you would suspect sleep apnea and refer that patient either for an in-lab or home sleep study. If you have a patient with hypernatremia and hypokalemia, then you should suspect potentially aldosteronism. And so getting either CT of the adrenal glands or this ratio of plasma aldosterone to plasma renin activity would be something that you would use to help further dive into their hypertension diagnoses. So I felt like this was very handy. You'll be able to have these in your slides, but just something to help guide you for if you're seeing things that don't seem quite right and you want to dive a little bit deeper, what are the diagnostic studies that are recommended for that? But again, primary hypertension is going to be your bread and butter hypertension. Some basic testing to do both upon diagnosis as well as you continue to monitor these patients. Your basic lab work, CMP, CVC, thyroid, UA, ECG, some optional testing that you can consider, getting an echo, particularly if the patient's had a really long-standing uncontrolled hypertension. We'll talk a bit about some of the cardiovascular risks here in a moment, but getting an echocardiogram, what essentially that's going to do is evaluate the patient for left ventricular hypertrophy. So the more long-standing and uncontrolled their hypertension is, the more that left ventricle is really having to work hard to get the blood out where it needs to go. And so over time, that myocardial wall becomes very thick. And the thicker that myocardial wall becomes, the more at risk the patient is. And so we'll talk here just for a second about some of the ECG changes that you may see with people that have uncontrolled hypertension. So with left ventricular hypertrophy, essentially those QRS complexes, which the QRS represents ventricular depolarization, that QRS is going to be very exaggerated in amplitude. So it's going to be very tall or more pronounced on your tracing, particularly in those precordial leads, because those are the leads directly overlying the left ventricle. So you may see something printed out on your ECG that says LVH by voltage criteria. What does that mean? That essentially means that the computer has calculated the depth of the S wave in V1, which is measured in millimeters, and then the height of the R wave in V5. And they're going to add those two together. And if that millimeter amount is more than 35, then by voltage criteria, that patient has LVH. So if you see that on your ECG, but you don't have an echo, you can say that ECG suggests LVH, but you would then confirm that with an echocardiogram. You also may note some LV strain, which is represented on the ECG by T wave inversion in, again, V5, V6. Those are the two leads that are looking most closely at the left ventricle. This is what it's going to look like on an actual tracing. So anytime you see your QRS complexes are falling on top of each other and the voltage is really high, where it's difficult for you to even tell where the top of your QRS even starts and where the bottom of the previous one ends, 9 times out of 10, that's probably going to be LVH from voltage criteria. And again, you can see here in V5, V6, where you have that T wave inversion evidence of LV strain. So this is a kind of late finding that you may see if someone presents to you with long-standing untreated hypertension. So if you have a patient that has new onset or very uncontrolled hypertension, what you're going to want to, again, assess for are some of these conditions that may suggest towards secondary hypertension. If it's drug resistant or potentially drug induced, if it's a very abrupt onset of hypertension where they have been well controlled for years and then suddenly they're at stage 2 hypertension, or if they're less than 30 years of age. Again, that patient population and prevalence is much lower. So this would be an unexpected finding. If they previously have been well controlled, but suddenly they're not, then that would be a cause for concern, or unprovoked or excessive hypokalemia. So if the answer is yes to any of those things, then you want to screen them for secondary hypertension. If they do then have a positive screening test, then the appropriate thing to do is refer them to the clinician with specific expertise to that underlying condition or disorder. So our next case study here, so over the next year, Ms. Smith's readings have continued to increase. She's been watching her sodium, she's walking, but her blood pressure still is remaining elevated. So today it was 138/88. Her routine labs are current and nothing really is significantly abnormal. So she asks if there's something else that could be causing her blood pressure to increase. So what would be your next step here? So you could offer to get a sleep study, reinforce other lifestyle modifications, get a CT of her adrenal glands, A and B, or all of the above. And I'll give you guys just a moment to answer. Okay, so we're kind of all of the above is the most common answer. So the answer here that would be most appropriate would be A and B. And the reason why I wouldn't select all of the above in this case is because for a CT of her adrenal glands, she would have to have had some laboratory findings suggestive of that. And so if we recall, her routine labs were current and there was nothing significantly abnormal. So while it wouldn't be wrong to do a CT of her adrenal glands, would probably focus initially on getting that sleep study to see if maybe untreated sleep apnea could be causing this. And again, reinforcing some of the other lifestyle modifications outside of sodium intake and walking as well. Patients often will say, well, it's because I'm here that my blood pressure is high. So there is actual white coat hypertension or masked hypertension. I'll kind of go through these a little quickly because I want to make sure I give Justin enough time here. But if their office blood pressure is, between 130, 160, and they've been doing lifestyle modifications, their home blood pressure monitoring has been less than 130/80, so they're coming in with their log and everything there is well controlled, then they likely may have some degree of white coat hypertension. If their office blood pressure is a bit more in that elevated BP range, and they've been doing their lifestyle modification, and their ambulatory or home monitoring is high, then you would suspect those patients for more masked hypertension. So the component of really seeing what their blood pressures are running at home is important. If I have a patient who's getting a blood pressure cuff to monitor their readings at home, I always ask that they bring it into the office to compare it with our manual cuff, just to make sure that it's maybe not perfect, but pretty close in the ballpark of what we're getting from a manual reading as well. It also gives the patient reassurance that what they're getting at home is going to be what we would get here in the office. So having that patient bring in their blood pressure log is very helpful. So this is just an overall recommendation as far as what their follow-up guidelines should be based upon their stage of hypertension. Those in that normal range, keep doing the healthy lifestyle things, see them on an annual basis. If they're elevated, reinforcing the non-pharmacologic therapy, check them again in 3 to 6 months. If they've crossed into the stage 1 and their 10-year risk score is greater than 10%, then if they're clinical atherosclerotic coronary vascular disease or their risk is more than 10%, if that's not the case, then again, that non-pharmacologic therapy. But if it is more than 10%, you want to then begin some blood pressure lowering medications that Justin will come up here with in a few minutes, and then reassessing them again at 1 month. If their goal is met, awesome, every 3 to 6 months. If it's still not met, monitor their adherence to therapy and consider intensification. Stage 1, stage 2 hypertension, you're definitely going to go straight to medications as well, regardless of if they have that more than 10% cardiovascular disease risk. This also talks briefly here about resistant hypertension. So this is when you have a patient who has been on 3 antihypertensives at optimal doses, including a diuretic, or if they are controlled but are requiring 4 or more antihypertensives. One, you want to exclude pseudo-resistance. So make sure that the blood pressure readings are accurate, make sure they're adhering to their regimen, make sure you're looking not just at office, but also their home or ambulatory readings as well. Making sure they're adjusting those lifestyle factors, stopping any interfering substances like NSAIDs, any stimulants like amphetamines, decongestants, oral contraceptives. Who knew licorice was a bad thing for hypertension, but if they have an obsession with black jelly beans, maybe have them stop that. But then you will want to, again, screen those patients for those secondary causes of hypertension, maximizing their pharmacologic treatment. And then if all those things have occurred and you're not making any progress, referring them to a specialist for further treatment and evaluation. Not doing anything harms our patients. So patients develop significant target organ damage as a result. These patients often have really worse cardiovascular outcomes. A statistic that I read that was somewhat alarming to me was that they did a meta-analysis of 1 million adults, and if they have a blood pressure more than 115/75, for every 20 millimeters higher systolic or for every 10 millimeters higher diastolic, their risk of death from heart disease and stroke doubles. So doing nothing, again, harms our patients. They're at significant risk for other cardiovascular complications. We also know that in our African-American patients with hypertension, they're more vulnerable to strokes and hypertensive kidney disease, 3 to 5 times more likely to have those renal complications and end-stage renal disease. These patients have different sensitivities to medications. They respond very well to thiazide diuretics and calcium channel blockers. So we need to make sure that we're considering the patient's race when we are talking about how we want to treat and how aggressively we want to treat their hypertension with the right kind of medication. So with that, I will end my portion and switch over to Justin.
Sorry, I'm pulling up my slides now. That should be good. So yeah, so I'm gonna kind of take off of what Tara talked about. After we evaluate, we properly diagnose and assess the patient's blood pressure. Now we look to how are we going to treat these patients. I know I'm a pharmacist, but I feel like I'd be remiss if I didn't throw another plug in there about non-pharmacologic treatment. Tara mentioned this, but at every step along the process, we need to be addressing this and making sure patients are taking these considerations into mind when they're trying to get a better control on their blood pressure. When we start to think about pharmacologic initiation, we've seen this algorithm on several slides to this point. Again, just as we're talking about what patients do we look to treat, it's going to be this stage 1 and stage 2, stage 1 hypertension in those patients that have clinical ASCVD or those at high risk for ASCVD or those that have diabetes or chronic kidney disease. We're going to go ahead and look to start pharmacologic monotherapy and assess 1 month after initiation, or those that are considered to be stage 2 hypertension, we're going to go ahead and initiate pharmacologic therapy and reassess 1 month as well. So pharmacologic strategies, this was an approach that was originally documented in JNC 8. Now there has been a couple new iterations of hypertension management guidelines since this, but I think the strategy approach still applies. So in these guidelines, they note 3 different strategies. The first one being strategy A, where we start one drug, we maximize this drug to its maximum dose, and then we add a second agent. Strategy B is a little different, where we start an agent, but we look to add a second agent before achieving that maximum dose. Both of these strategies are very valid and very much can affect different patients in different ways, and so it may be something to consider. Strategy C is to begin 2 drugs simultaneously as either separate pills or a combination pill if it exists. And it actually is recommended that a combination therapy be started in patients if their blood pressure is consistently falling greater than 20 millimeters of mercury systolic or greater than 10 millimeters of mercury diastolic above goal. So something to keep in mind. So when we start to think about what agents are we going to recommend for these patients, the newest iteration of guidelines recommend 4 different drug classes for appropriate first line. These include thiazide diuretics, calcium channel blockers, ACE inhibitors, or angiotensin receptor blockers, which I'll refer to as ARBs throughout the presentation. It is important to note that these can be used in combination, and most likely it's going to be recommended that we do so in the appropriate patients, with one caveat. And we'll get to this later in the presentation, that ACE inhibitors and ARBs should not be used in conjunction, and we'll dive into that a little bit further when we talk about those agents individually. So throughout the presentation, you're going to see this table. A lot of it is for your all's reference. At the top, it's going to have the agents within the class and their appropriate doses up to their maximum doses, as well as some pricing concerns that you may see with these different agents and some caveats with that. I'm going to spend the bulk of what I talk about in these middle sections with monitoring possible side effects and pearls through these agents. So with thiazide diuretics, they are what their names say, they are diuretics. So when it comes to monitoring, it is recommended that electrolytes and renal function are both highly considered, and maybe checking labs 7 to 10 days after initiation. With side effects, because of their diuretic effect, it's possible that patients may experience some dehydration. Other side effects specific to the thiazides include hyperuricemia and hyperglycemia at larger doses. So that would be something to keep in mind for patients that have concomitant gout or in patients that have diabetes. Didn't mean to go forward yet. Some pearls to keep in mind. In the next slide, it kind of gave it away, but these agents are generally not going to be as effective in patients with diminished renal function, specifically in those that have a creatinine clearance less than 30 milliliters per minute. There is some evidence to support indapamide at a lower cutoff, but it's just as a general rule of thumb, 30 is where we want to target and where these agents may not be as effective any longer. Something that a lot of providers may not realize, but chlorthalidone is the preferred thiazide diuretic based on the prolonged half-life compared to its alternative agents. So definitely something that you'll see later in the presentation and why we want to keep that in mind. So this is just a snapshot that I pulled online, looking at the area that different diuretics and different agents will work in the kidney and the nephron. If you look at where the thiazides exert their action, it's going to be later or that distal part of the nephron. And so therefore, when patients have diminished renal function, that's why we may not see as pronounced of an effect on the blood pressure. So as our patients get older, we know that their renal function may decline. And if that happens, these thiazides may not be as efficacious as they once were. So now we'll move into our second first-line agent class, and this is the calcium channel blockers. When we think of calcium channel blockers, this is really split into 2 different sub-classifications. The dihydropyridine classes, which is imlodipine, nifedipine, felodipine, and nicardipine, and the non-dihydropyridine classes, diltiazem and verapamil. The dihydropyridine calcium channel blockers are more prevalent and exert their action more in the peripheral vasculature. And so therefore, these agents are going to have more of a pronounced blood pressure lowering effect versus the non-dihydropyridine class is going to exert their action more in the cardiac musculature and therefore may have a more pronounced effect on the heart rate in patients. So when we're looking to start blood pressure agents, unless we have a strong reason to lead us to choose the non-dihydropyridine class, you may see a more pronounced blood pressure lowering effect with the dihydropyridine calcium channel blockers. This slide, again, same as before, has the agents and their doses at top. When it comes to monitoring, the dihydropyridine classes are pretty well tolerated. We do have to keep patients' heart rates into consideration with those non-dihydropyridine classes. As far as side effects go, both can be associated with some peripheral edema, some orthostasis, some reflex tachycardia. Verapamil has been associated with some constipation, so something to consider if patients present with any of these side effects. One clinical pearl that I'd like to note for both of these agents, the guidelines currently recommend that we avoid calcium channel blockers in these patients with heart failure with reduced ejection fraction. So something to keep in mind, a lot of the other agents that we use in heart failure are going to lower patients' blood pressure anyways. So it may be something that we need to discontinue the calcium channel blockers to allow for dose titration of the other agents in those patients. You may be able to use non-dihydropyridine classes in patients with migraine for the use of migraine prophylaxis, but we do need to be cognizant that these agents are associated with more drug interactions as well. So now we're going to move into our last two classes of first-line agents in the treatment of hypertension, and this includes ACE inhibitors and angiotensin receptor blockers. So this is a screenshot of our renin-angiotensin-aldosterone system, and from a very high surface level, this is the pathway that we would normally undergo that raises our blood pressure. At the end of the line, we see the aldosterone as a final end product, and aldosterone leads to a bunch of different pathways that can end up increasing patients' blood pressures. So you can see where the ACE enzyme acts, blocking that degradation or that conversion from angiotensin 1 to angiotensin 2, preventing the end product. Similarly, a little bit downstream, you see that blockade or receptor antagonism at that angiotensin receptor. And so you can see that the ARBs work a little bit downstream from the ACE inhibitors, and so therefore using them in conjunction really do not add any benefit and is going to be recommended against. And so if you see patients that come in that are on lisinopril and losartan, that's definitely an opportunity to discontinue one of these agents and maximize and optimize the others. So first, we'll talk about the ACE inhibitors. These are our agents that are in with our prils, so those doses are listed above. With monitoring, because they work in the kidneys, we will see very commonly a bump or a transient increase in patient serum creatinine. And this is going to be, the guidelines actually recommend up to a 30% increase is acceptable. So if you see, or if you draw labs in patients, which is usually done about a week or two after initiation of these agents, if you see an increase in the serum creatinine, it should be expected. So not necessarily anything that should cause too much concern, but something to definitely keep in mind as patients represent. These agents can also have an increasing effect on potassium, so keeping that lab in mind as well. I'm sure we've all ran across patients or have heard of at least the dry cough that can be associated. On the next slide, I'll dive into that a little bit further. And then more seriously, the side effect of angioedema. If patients present with any swelling of their lips, tongue, oral cavity, we want to make sure that we are assessing and appropriately discontinuing these agents. It is of note, I'll get to a later slide looking at treatment of hypertension in our pregnant population, but these agents are contraindicated in patients that are pregnant and those patients that have bilateral renal artery stenosis. So back to our slide looking at our RAS system. Here's what I wanted to draw your attention to. The ACE enzyme also allows the breakdown from bradykinin to the inactive peptides. And so by blocking this, we have an increased circulation of bradykinin, which has been proposed to be the mechanism for what drives that cough in those patients. So as you can see downstream, the ARBs do not affect that breakdown of bradykinin. And so therefore patients that have a cough with ACE inhibitor use do not typically have that with the ARBs. So if you look at this slide, you have your ARBs listed up at the top. You're going to notice that they are very, very similar to the ACE inhibitors. And that's because, like I said before, they are very similar in how they work and what their end goal is. So monitoring is basically the same, that same transient bump. The potassium can still go up. There has been some associated angioedema, albeit this is less than the ACE inhibitors, and they can be used in these patients, but recommended with extreme caution. So the next few slides really highlight how we look to use these different agents in our different patients. At the end of the day, we're going to want to consider patients, all of their comorbidities when selecting agents. Very, very infrequently will we have patients that have elevated blood pressures alone. They typically present with a multitude of different comorbidities or disease states, and we need to let these disease states drive our therapy so that we are, killing two birds with one stone. So just running through these different conditions, for both diabetes and chronic kidney disease, we are going to let the presence of albumin in patients' urine really drive whether or not we need to select a certain agent or not. So if there is the presence of albumin in the urine, as outlined by the measurements for the albumin to creatinine ratio in the considerations column, we're going to look to start an ACE inhibitor or an ARB. If there's the absence of albumin in the urine, then any first-line agent would be clinically appropriate. When looking at patients with heart failure, again, this is going to depend on if they have that heart failure with reduced ejection fraction versus the heart failure with preserved ejection fraction. But using our guideline-directed medical therapy is going to be what we're going to recommend for blood pressure lowering. ACE inhibitors or ARBs or ARNI, guideline-directed medical treatment with beta blockers, mineralocorticoid receptor antagonists, and of course diuretics if clinically appropriate. In the considerations column, I did note again to avoid those non-dihydropyridine calcium channel blockers, as they can worsen some of our peripheral edema, as well as we need to allow room for dose titration with our recommended first-line agents. In patients with stable ischemic heart disease or those post-acute coronary syndrome or myocardial infarction, we're going to look to use ACE inhibitors or ARBs as well as beta blockers for first-line agents in this class, but dihydropyridine calcium channel blockers can be utilized if patient continues to experience angina as a secondary complication. As far as secondary stroke prevention, it is recommended as thiazides as well as ACE inhibitors and ARBs. And it is noted that you may need combination to achieve that tight blood pressure control that is warranted in these patients. In atrial fibrillation, any first-line agent would be acceptable, but you may have to keep in mind that patients may be on a beta blocker or a non-dihydropyridine calcium channel blocker for rate control in the disease state of atrial fibrillation. There has been some evidence to support the use of angiotensin receptor blockers and their ability to prevent reoccurrence of AFib. So this may be a good agent to help lower blood pressure as well. And in patients that have documented aorta disease, it is recommended to have a beta blocker on board. And we'll get into beta blockers a little later in the presentation. So as I previously mentioned, and as did Tara, we need to keep our patients' characteristics into consideration when we're selecting agents. I know Tara briefly touched on our African-American population, and so those without comorbid conditions, the initial therapy should include a thiazide and or calcium channel blocker. And this is because they have a less active RAS system, and so those ACE inhibitors and ARBs are not going to be as effective in this patient population. However, I do want to note that it's still a very acceptable add-on for patients for their blood pressure control, and we shouldn't shy away from these agents, but more so just make sure that we have a thiazide or calcium channel blocker on board first. It is of note, similar to what Tara said, that these patients rarely achieve blood pressure and are more difficult to get to goal, and so it's very rarely achieved with monotherapy and typically will require multiple agents. For our patients that are pregnant, it's going to be recommended that we transition these patients to agents that have established safety. And these currently include labetalol, nifedipine, and or methyldopa, all of which are going to be in different parts of this presentation. Thiazides are currently not recommended. And like I said before, those ACE inhibitors, ARBs, and direct renin inhibitors are contraindicated and are pregnancy category X. So let's get back to Ms. Smith. Just as a reminder, because we need to keep patient characteristics in mind, Ms. Smith is a 63-year-old African-American woman who has a past medical history of GERD and hyperlipidemia, treated with a statin. She returns for her 6-month follow-up appointment where she provides you with her blood pressure log from the past 2 weeks. So she took your recommendations and she started keeping her blood pressure pretty consistently. Those readings fall between 160 to 169 systolic, over 90 to 99 millimeters of mercury diastolic. Again, as we always should, you have reinforced lifestyle adjustments and appropriate non-pharmacologic strategies. Her labs have been reviewed and all are within normal limits. So my question for you guys is, what would you like to initiate for the pharmacologic management of Ms. Smith's hypertension? A, amlodipine, B, lisinopril, C, chlorthalidone, D, clonidine, or E, both A and C? And I'll give you guys a few moments to answer. All right, so you guys are picking up on some of the points that I'm trying to get across with this question. Yes, the correct answer, or in my opinion, the most appropriate answer for this question would be E, both A and C. Again, we want to let our patient characteristics drive. And so being an African-American patient, we know that this is going to be more, the agents that would be more efficacious would be the calcium channel blocker and the thiazide, as well as her blood pressure readings really suggest that she should be started on 2 first-line agents rather than monotherapy at this time. So both initiating amlodipine and chlorthalidone would be the most appropriate approach at this time. So let's talk about resistant hypertension. Tara did a great job earlier just defining this and evaluating. So I'm going to move on to a little bit deeper in that drug-induced hypertension that can be listed as a secondary cause of patients that present with resistant hypertension. NSAIDs are going to be what I commonly see the most. Patients are in the hospital and I'm going through their medicines with them and evaluating, and lo and behold, they take, ibuprofen around the clock for some chronic knee pain. And then we have to have the discussion, well, that can actually worsen your blood pressure. So assessing for these things or these agents that can commonly work against what we're trying to achieve with our treating hypertension are going to go a long way. So this is listed here, and for your review as possible or potential things or agents that can worsen blood pressure and make it more difficult to control. So this algorithm is listed in the newest iteration of guidelines from the ACC/AHA, and it has a stepwise approach, which is pretty straightforward and easy to consider. Step one, again, we're going to exclude other causes and optimize the current regimen. Make sure that patients are on their maximally tolerated doses of the first-line agents and assessing for any non-pharmacologic or lifestyle modifications if possible. Always, first and foremost, we should do that before we look to add medications and make patients' medication regimen more cumbersome. Step two, as I mentioned briefly on the thiazide diuretic, chlorthalidone has evidence to support that it's the most efficacious thiazide-like diuretic. And so if they are not already on chlorthalidone, the second step in this algorithm is to substitute one of those other thiazides with chlorthalidone if they are not already on it. Step three, we'll look to add a mineralocorticoid receptor antagonist. Step four would be to consider a non-first-line agent, looking at beta blockers first and foremost if the heart rate allows, alpha agonist, or a non-dihydropyridine calcium channel blocker if they are not on the dihydropyridine class. Step five would be to consider the addition of vasodilator hydralazine. And then step six would be to substitute minoxidil for hydralazine if patients are still not at goal. So then now we're going to go into some of the different classes that we would look to in patients that present with resistant hypertension. So first, kind of working through that algorithm would be the mineralocorticoid receptor antagonist. This includes medications spironolactone and eplerenone. So similar as to before, I have this chart that lays out the different aspects with monitoring side effects and pearls. For these agents, I've added a row that is essentially their role in therapy. And so I'll highlight those throughout the presentation as well. So for these agents, it is important to, again, because they work in our kidneys, to monitor serum creatinine as well as potassium. With these agents, it is recommended to draw some labs about 1 to 2 weeks after initiation. Side effects that have been documented include gynecomastia or mastodynia, specifically with spironolactone, but both of these agents have been associated with hirsutism as well. These agents are contraindicated in patients with severe renal dysfunction, so those that have a GFR less than 30 milliliters per minute, adjusted for their body weight, potassium greater than 5 milliequivalents per liter. These are commonly referred to potassium-sparing diuretics. So we know that these are used for patients that may have hypokalemia when they're on concurrent diuretic therapies for other comorbidities. And so we know that if they are high potassium, then we need to avoid these agents. And then lastly, if patients are not producing any urine, these agents would have to be avoided as well. And specifically for these roles in therapies, of course, as we're talking about it for resistant hypertension, but these are also agents that are included and recommended use for our patients that present with heart failure, both reduced and preserved ejection fractions. So now let's talk about beta blockers. As you can see in the role of therapy row down there, there is a whole slew of comorbidities that these are utilized. And so it may be the case that patients are already on a beta blocker when you are treating their hypertension, and you may just have to keep that in mind when you are looking to titrate different doses. The biggest monitoring that we have to consider with beta blockers is because they can affect or act in our, or assert their beta blockade on our beta 1 receptors, that it can affect our heart rate and lower patients' heart rate, as well as affect their blood pressure. This is going to be more pronounced depending on their cardioselectivity, and so you may want to refer to some of your different agents or use your pharmacist to help you determine which agents have more, which are more non-selective versus which ones are more cardioselective in nature. As far as side effects go, bradycardia with a low heart rate, exercise intolerance, generalized fatigue, or even sexual dysfunction have been reported. Some pearls include to use caution of non-selective beta blockers with respiratory disease. Some non-selective beta blockers, just for your notes, would include things like propranolol, nadolol, some labetalol. With that, all beta blockers can mask the signs and symptoms of hypoglycemia. So we want to make sure that we are considering that and educating our patients if they have concomitant diabetes. These agents are going to be avoid to avoid abrupt cessation. And if we are going to discontinue the beta blocker for any reason, that we try to work that off over time. And then patients that this would be contraindicated in include those with decompensated heart failure, as well with any patients that have documented AV nodal dysfunction or any kind of heart block associated arrhythmias. As we move throughout our resistant hypertension algorithm, next we have our alpha agonists. This would include both clonidine and methyl-dopa. These are a little bit further down our algorithm, mainly because of the side effect profile that they have associated with them. So a lot of patients typically experience at least one of the side effects that you see listed there, including dizziness, dry mouth, drowsiness, or orthostatic or orthostasis. And so this is something to keep in mind, and we may have to dose these at closer to bedtime if patients are experiencing, any or all of these side effects. Something to keep in mind with clinical pearls, some of those side effects are a little bit diminished or not seen as much if you are able to transition a patient to the clonidine patch. But as you can see at the bottom with pricing, there may be some variable coverage or pricing with the patch, and you may have to address that if that's something that you'd like to initiate for your patients. So something to keep in mind, side effect profiles a little bit more associated with these agents, and I would definitely work through the other medications before getting to these options. Now we'll talk about the last two steps in the resistant hypertension pathway, and these are our vasodilators, specifically hydralazine and minoxidil. One big caveat with these medications is these typically need to be dosed multiple times per day. So if you have a patient that has a really hard time remembering to take medicines, these may not be good agents to initiate for those patients, as you are going to have to dose them multiple times throughout the day. Monitoring with these, as you see with their side effects, hydralazine specifically can cause some tachycardia, but both of these agents can result in some fluid retention or some lower extremity edema. So because of that, these agents should be, and it is recommended to be coupled with a diuretic and a beta blocker, so that we are not seeing these pronounced side effects of tachycardia or fluid retention. Hydralazine specifically has been associated with headache or a lupus-like syndrome, most commonly a rash, at higher doses, documented to be greater than 200 milligrams total per day. One big pro for these medications is they do not require any renal dose adjustments. So a roll-in therapy is definitely going to be our patients on hemodialysis. Both of these agents can be used and pretty effectively lower blood pressure, when a lot of our other agents we have to use with caution or are contraindicated if they are have severely diminished renal function or are on dialysis. So now we're going to get into salvage therapy. So these are agents that really we should have worked our way through a lot of our other agents before we get to, but these are our alpha blockers. These are more so in the salvage therapy category because of their side effect profile, but also because they do not have a very pronounced effect on lowering blood pressure. And so you're really maybe not getting as much bang for your buck when you consider the side effects that these agents could be presenting. These side effects typically include dizziness or orthostasis, and patients, because of this, it's recommended that we start these on the lowest dose and titrate very slowly to make sure patients don't experience this. And we may have to consider dosing these medications at bedtime to make sure that they are not having these side effects throughout the day. However, patients that have concomitant BPH, these are going to be recommended agents to begin with. So you may be able to use these use these medications for more than one indication. Loop diuretics, I placed this on the presentation more so because even though we don't recommend using these in hypertension, certain patients that have chronic kidney disease or those that have concomitant heart failure, you're likely going to see them on a loop diuretic at some point in time. And a lot of times these medications are dosed based on the desired diuretic response, and the dose the blood pressure lowering effect is very dose related. So these medications can lower blood pressure, and just we may have to keep that in mind while they're on these for these other comorbidities. So with monitoring, of course, we're going to monitor renal function as well as electrolytes, as well as assessing patients for dehydration. And at high doses and at toxicities, patients may report a side effect of tinnitus or the ringing of the ears if they are experiencing any toxicities with these medications. So let's go back to Ms. Smith one final time. She comes back for her 1-year scheduled wellness visit and presents her medication regimen below. You review her labs and vitals. They're listed there at the bottom, so we'll get to those. Again, you reinforce adherence, make sure she's taking all of her medicines, and the secondary causes of blood pressure have been excluded. So her medication regimen now is amlodipine, 10 milligrams a day, chlorthalidone, 25 milligrams a day, and lisinopril has now been added at a dose of 20 milligrams per day. Her labs and vitals includes a serum creatinine of 1.3, which is now considered patient's baseline, and her potassium at this time is 5.2 milliequivalents per liter. Her blood pressure log that she's provided shows that her blood pressure looks a lot better than before, but is still elevated compared to where we would like it. Her heart rate is consistently in the 80s and is 80 beats per minute at this time. So you decide you want to change or optimize her medications further. And what would be your next step to better control Ms. Smith's hypertension? Would you go with adding spironolactone, adding carvedilol 6.25 milligrams twice a day, increasing lisinopril to 40 milligrams a day, clonidine 0.1 milligrams twice a day, or adding furosemide 20 milligrams daily? And I'll give you guys a few more moments to answer this. So it sounds like we're a little bit split. I was a little afraid of that with this question. There's multiple approaches you could do. Given the patient's labs and how they're presenting, I think the most appropriate answer would be to go ahead and initiate a beta blocker with carvedilol 6.25 twice a day. It looked like most of you guys avoided spironolactone, and that's probably because of the potassium reading. Just as a reminder, both our ACE inhibitors and our angiotensin receptor blockers can also have an increasing effect on lisinopril. You may not see as pronounced of effect with the spironolactone, but you may want to avoid increasing that dose any further at this time. One could argue you would want to stop or hold the lisinopril if you were worried about the potassium, as it does continue to increase. Clonidine, we're probably going to wait and at least trial a beta blocker before we go to that agent. And as I said before, furosemide and our loop diuretics is not something that's currently recommended for blood pressure lowering, but if a patient has chronic kidney disease or heart failure, then we would look to initiate those agents. So it looks like we're running close on time. So hypertensive crisis, Tara actually touched on this earlier, so we'll go ahead and skip to this. Strategies to improve hypertension, again, assessing the adherence, keeping cost in mind. I do want to note that basically, if not all, most of these medications are generic. And so they usually have minimal pricing concerns, but these would be good agents to utilize our savings cards like GoodRx. It also is recommended to try to use combination formulations when available. Using team-based approach, using telehealth when appropriate is going to be ways to further help optimize our strategies to improve adherence and overall treatment. And then lastly, just summary slide. I don't necessarily need to restate any of these because I feel like we've said them throughout, but just help use characteristics to drive therapy. And lastly, there has been some evidence to support dosing medications at bedtime if we are close to goal, but not quite there. So that'll conclude my portion of the presentation.
Thank you, Justin and Tara. It looks like we have one question in the chat. Amanda's asking, coming from an ICC setting, of course, I always recommend patients with elevated blood pressure. Sorry, it moved because the chat's still coming in. Follow up with or establish care with a primary care. But is there any instance we should be initiating antihypertensive therapy for patients with consistently elevated blood pressure readings? If so, recommended therapy to initiate in the setting, knowing that we cannot order a BMP or a CMP. And I think Tara was prepared to answer this one.
Sure. So first, Amanda, I love your heart is in taking care of the patient and making sure that they have what they need. I think, in the absence of a hypertensive crisis, which would recommend sending that patient to the emergency room for to be evaluated, I would not recommend starting anything kind of blindly, because while we use a lot of these medicines very often and they seem somewhat benign, they can cause harm if we haven't done some underlying evaluation of their renal function, their electrolytes. And so in this instance, I would really try to help get them to that next step, to establishing care with primary, but I would not start anything blindly unless they're in hypertensive crisis, and again, send that patient to the emergency room.
Awesome. Thank you, Tara. And I see that Tara also answered Kara's question in the Q&A with a written response. I just want to thank everybody for participating today. Please make sure to fill out your evaluation and join us on Wednesday, July the 27th at noon. We will focus on talking about diabetes. Thank you, Tara and Justin and everyone who participated.
My pleasure. Thank you so much.
Thanks. Bye.